All right, so we'll go ahead and get started. My name is Alexis Jones. I'm an oncology pharmacist practicing at the University of North Carolina. I'm specifically in our gynecologic oncology clinic, so today I'll be covering gynecologic malignancies. These are my relevant relationship disclosures. And for our learning objectives, we're really going to cover and focus on the first learning objective. So in addition, there will be a handout, and I would refer you to that for the second and the third objectives, as well as we're only going to cover ovarian cancer today, and there is endometrial as well as cervical cancer that are in the handout. So for the first objective, we want to design an appropriate patient-specific treatment, management, and monitoring plan taking into consideration efficacy and safety outcomes of clinical trials and current treatment guidelines for a patient with a gynecologic malignancy. Additionally, discuss short and long-term goals, including post-therapy and survivorship with a patient with a gynecologic malignancy and her caregiver. And then finally, select relevant information and provide guidance for the public regarding gynecologic malignancy-related issues, such as risk factors, prevention, and screening. So jumping right into the primary treatment for ovarian cancer, we first have our first audience response question, which is, JJ is a 57-year-old female who presented to the emergency department with 17 days of abdominal distension and 3 days of abdominal pain. Physical exam revealed a mass in her right lower abdomen. Laboratory results were notable for a hemoglobin of 7.1 and a CA-125 of 212. Ultrasound confirmed the presence of a mass, and imaging ruled out any distant metastases. The patient is clinically staged with a 1B high-grade serous ovarian cancer and underwent adequate surgical cytoreduction. Which of the following is most appropriate management for JJ at this time? A, carboplatin and paclitaxel for 3 cycles. B, observation. C, carboplatin and paclitaxel for 6 cycles, or D, carboplatin, paclitaxel, and bevacizumab for 6 cycles. All right, very good. So C is the correct answer, carboplatin and paclitaxel for 6 cycles. And the key here is really that the patient has a stage 1B, so we do want to treat her with some sort of chemotherapy. Therefore, observation wouldn't be an option. But again, she's stage 1B, so she's early stage, so doing something like carboplatin, paclitaxel with the addition of bevacizumab would not be indicated in this early stage. And the 3 versus the 6 cycles, we're going to choose 6 cycles in this patient given the fact that she has high-grade serous. And we'll get into some of the data behind that, but because she has that high-grade serous, we would favor doing 6 cycles. Okay, so jumping into the surgical management. So even in these early stage patients, we are going to be, surgery is still going to be an important part of their treatment. And for surgery, we're going to be doing comprehensive surgical staging, which includes a total abdominal hysterectomy, bilateral salpingo-oophorectomy, pelvic and para-aortic lymph node dissections, omentectomies, radical pelvic dissections, and potentially other resections if appropriate. And the goal here is really to get what we call an optimal cytoreduction, which means that we have less than 1 centimeter of visible disease remaining at the time of closure. Suboptimal would be if there's greater than 1 centimeter left, and a microscopic or an R0 resection would be that there's nothing visible at the end of surgery. And so even with our early stage, like I said, I did indicate that we do need to do surgery for these patients, but if someone still desires fertility and they're early stage, you do have some options for fertility-sparing procedures. So if it's a 1A, you're able to do a unilateral salpingo-oophorectomy, followed by surgical staging once the patient is done with fertility or no longer desires fertility. And then 1B, you're able to do a bilateral salpingo-oophorectomy, but still sparing the hysterectomy at that time. If they're stage 1 through 2 or they don't desire fertility at this time, we would still favor that comprehensive surgical staging. So jumping into chemotherapy for our stage 1 ovarian cancers. So our stage 1A and 1B, if they're low grade, a low grade serous or a grade 1 or grade 2 endometrioid, we would be potentially have an option of doing surgery followed by just observation. With grade 2 is potentially where we'd be looking at some chemotherapy, but could still opt to do observation for these patients. Once we get to the higher grade or those grade 3 endometrioid or even stage 1C, we are going to be offering chemotherapy for these patients. And we're going to be doing a platinum-based chemotherapy for 3 to 6 cycles with favoring 6 cycles for that high-grade serous. And so what chemotherapy are we using for these patients when I say a platinum-based regimen? So our preferred platinum-based regimen is going to be carboplatin with an AUC of 5 to 6 and paclitaxel at 175 milligrams per meter squared. This is given every 3 weeks, and again, we're going to be looking at 3 to 6 cycles depending on the histology. Some other options, if patients cannot tolerate or cannot receive paclitaxel, you still want to give the carboplatin, but you do have the option of substituting it out for pegylated liposomal doxorubicin or potentially for docetaxel. These are still given for the 3 to 6 cycles though. And so GOG 157 is really where we find the data to support that high-grade serous ovarian cancer should be receiving 6 cycles of chemotherapy. So these were patients with high-risk features, but still early stage. So still those stage 1A, 1 or 1B with a grade 3, or potentially 1C, 2, or a clear cell histology. They are randomized to either 3 or 6 cycles of our traditional carboplatin and paclitaxel. And what we found was there was lower recurrence rates with 6 cycles, but we also saw greater toxicity and no overall survival benefit. So for this reason, that's why it's an option that you could do 3 or 6. I will note here that the carboplatin dose that they used in this trial is a higher AUC than we are standardly giving. So the carboplatin AUC was 7.5 in this trial rather than the 5 to 6 that we're typically seeing. So they did do a subgroup analysis from this though, and they did find that patients with that high-grade serous tumors did benefit from 6 cycles. So they had a lower risk of recurrence, and you can see their 5-year recurrence-free survival here with 6 cycles being around 83% and 3 cycles being only 60%. And so just in summary, for stage 1 ovarian cancer, we are still, if they're 1A or 1B, we may have some options for fertility sparing. Otherwise, we are going to be offering a comprehensive surgical staging for these patients. And then in terms of chemotherapy, we're going to be looking at that preferred regimen of carboplatin and paclitaxel, but do have the option to substitute it out for that liposomal doxorubicin or docetaxel. And so then jumping into the stages 2 through 4 for cancer, or for ovarian cancer, again, we are still doing this complete surgical staging for these patients, but the chemotherapy is a little bit more important and a little bit more, plays a more important role in these patients compared to those early stage. So for these patients, our preferred regimen is still going to be carboplatin at the AUC of 5 to 6 and paclitaxel at 175 milligrams per meter squared. Now here we also have in our preferred regimen the option of adding that bevacizumab. Given that it's a more advanced disease, it is an option to do it with their concurrently with their chemotherapy and then continuing as a maintenance. There are 2 different dosing strategies for bevacizumab. You can do 15 milligrams per kilogram or 7.5 milligrams per kilogram. And then other options that we have for these patients, you can still do carboplatin and docetaxel. And then you have the option of adding bevacizumab to that regimen. You can do carboplatin and pegylated liposomal doxorubicin. You can also do paclitaxel in a weekly fashion with the carboplatin still at every 3 weeks, or you can do them both weekly, so weekly carboplatin plus weekly paclitaxel. And then additionally, for those patients that are going to be specifically stage 2 or 3, we do have the option for intraperitoneal chemotherapy, which is paclitaxel given as an IV on days 1, and then day 2 would be cisplatin as an intraperitoneal, and then paclitaxel on day 8 as an intraperitoneal therapy. We'll get into some more details about which patients we would potentially select for intraperitoneal and some of the data behind that in just a bit. And then for patients that are greater than 70 or patients with significant comorbidities, we may be looking at adjusting their regimen for better tolerability. And so what we see here is we still have a carboplatin with the AUC of, we usually just do 5 here rather than the 5 to 6. And then the paclitaxel is going to be brought down from 175 down to 135 milligrams per meter squared. Additionally, you do have the option of doing a weekly carboplatin and a weekly paclitaxel in order to, just for tolerability for this patient population. And so I do want to cover some of the data behind this. So in our first-line chemotherapy in elderly patients, we have patients that were newly diagnosed greater than 70 years of age, stages 3 through 4 with several comorbidities. And they were randomized to either that standard carboplatin and paclitaxel regimen, a single agent of carboplatin, or that weekly regimen that we see of that carboplatin at an AUC of 2 and paclitaxel at 60 milligrams per meter squared. And what we see here is that really the inferior arm here is going to be that carboplatin as a monotherapy, and that's why you don't see it in the recommendations, but the other two are options for the patients. Now again, this one did the standard of the paclitaxel at 175, and the recommendation that we were seeing in the NCCN guidelines is that 135. And so dose-dense paclitaxel is an option. It's listed, but it's not a preferred option. One of the reasons is really because the literature is conflicting here. So in JGOG 3016, we saw newly diagnosed stages 2 through 4, and the intervention was either the standard carboplatin and paclitaxel given every 3 weeks or carboplatin given every 3 weeks with a weekly paclitaxel. And what we saw in this trial was a significant improvement in progression-free survival as well as overall survival with increase in the grade 3 anemias. This was followed up by then ICON 8, which was newly diagnosed stages 1C through 4, and the intervention was that standard carboplatin and paclitaxel every 3 weeks, carboplatin every 3 weeks with a weekly paclitaxel, or both the carboplatin and the paclitaxel given in a weekly fashion. What we saw here is that there's no improvement in progression-free survival, and the overall survival was still preliminary, but what we did find is an increase in the grade 3 toxicities. So it didn't quite agree with the initial JGOG 3016, which is why it's not listed as a preferred option, but it's still available if that's something that you would like to select for your patient. So jumping into intraperitoneal chemotherapy, so GOG 172, this is for stage 3 optimally cytoreduced patients, and they received either cisplatin and paclitaxel, both in IV formulation, or they received paclitaxel at 135 milligrams per meter squared IV on day 1, and then cisplatin at 100 milligrams per meter squared intraperitoneal on day 2, and then paclitaxel 60 milligrams per meter squared intraperitoneal on day 8. What we see here is that there's a significant benefit in both progression-free survival and overall survival in the patients that received intraperitoneal chemotherapy. But what I'd also like to draw your attention to is how many patients were actually able to complete all 6 cycles that were planned. You can see in the intraperitoneal group that it was only about 40% of patients that were able to complete all 6 cycles compared to about 80% in the intravenous group. Now, the reason for this is largely because of toxicity. So if you look at the other table on this slide, you'll see that there were significant toxicities with the intraperitoneal group, significantly more than what we see in the intravenous group. So for this reason, if we are going to select a patient for intraperitoneal therapy, we do have to make sure that we think very carefully about the patient that we select, make sure that they qualify, and then there's also some supportive care things that we can do to help the patient through this regimen. So for our intraperitoneal chemotherapy, so who is the right patient? So again, this is going to be those patients 2 through 3. It is listed under in the NCCN guidelines for the 2 through 4 chemotherapy with the caveat that they only recommend it for those that are stages 2 through 3. They do need to have optimal cytoreduction, and they should not have any sort of bowel resection at the time of their primary surgery. They need to have a good performance status with really no other comorbidities, no pre-existing neuropathies, no pre-existing renal dysfunction. And so once we have the right patient, what can we do to help them through this therapy? So one thing that we're able to do is warm that intraperitoneal fluid. We want to warm it to body temperature. We don't want to instill it at the temperature of the room because it will be quite cold and uncomfortable for the patient. And then again, you're going to want to do aggressive oral and IV hydration, both pre and post therapy. This is the time that oftentimes that day 8, when they're coming for paclitaxel, they may receive additional IV fluids just to try and help with the hydration. Given that the cisplatin is in the intraperitoneal space, it's absorbed over a longer period of time. So in terms of the toxicities we see from cisplatin, they can be prolonged. And again, along those same lines, we're going to want aggressive antiemetics because of that prolonged exposure to cisplatin. Some modifications that we do in clinical practice, so the GOG 172 trial, they have the paclitaxel given in the traditional old-fashioned way of over 24 hours, but now we can give it over 3 hours, so that's often what we would do in practice. And additionally, the original study was using cisplatin at 100 milligrams per meter squared. This is often dosed down, and in the NCCN guidelines, they do have it as a recommendation to be somewhere between 75 and 100 milligrams per meter squared. So most of the time in practice, you'll be seeing 75 milligrams per meter squared. And this brings us to audience response question number 2. So SM presents for a pelvic ultrasound that confirms a left adnexa mass that's 3 by 2.6 by 2.3 centimeters, and subsequent biopsy reveals high-grade serous carcinoma. Additional staging confirms the SM has a clinical stage 4B based on pleural effusions and liver lesions, ovarian cancer, and is deemed upon imaging and in consultation with surgery to be unlikely to be optimally cytoreduced. So which of the following is the most appropriate initial therapy for SM? Is it A, staging with the TAH-BSO followed by carboplatin and paclitaxel, B, IP/IV carboplatin and paclitaxel followed by interval debulking surgery, C, carboplatin and paclitaxel followed by interval debulking surgery, D, carboplatin and gemcitabine plus bevacizumab? All right. Very good. So what the key here for this patient is the fact that they are unlikely to be optimally cytoreduced. So in this case, we're not going to be opting for surgery up front. We're going to want to give them some chemotherapy to see if we can get them to a place where they can be optimally cytoreduced. The IP and IV regimen is only an option if patients have been optimally cytoreduced. And then again, the carboplatin, gemcitabine, and bevacizumab, it's not one of our preferred agents or preferred regimens, but also there's no surgery involved in that option. So then moving into neoadjuvant chemotherapy. When do we do it, and what is the role for neoadjuvant chemotherapy? So as we discussed, these are really for patients with bulky disease that are unlikely to be optimally cytoreduced, or if they're potentially a poor surgical candidate. Now, we do still require histology confirmation of the diagnosis, so just because we haven't done their complete surgical staging, we still need to confirm what their disease is. What we typically do in terms of interval debulking surgery, the ideal is to give them 3 cycles of their chemotherapy, re-image them, and see if we're able at that point in time to take them to the OR for their optimal interval debulking surgery. If we feel like that's still not possible after 3 cycles, then we will potentially give them all 6 cycles up front. But one of the keys is even after their interval debulking surgery, they will still have additional chemotherapy with 3 cycles after their surgery. So if they're able to do 3 surgery and then 3 more, they get their total of 6 that way. Sometimes, though, they do get the full 6 up front surgery and then 3 more after, totaling 9. And so interval debulking surgery, after interval debulking surgery, what are our options for chemotherapy as the neoadjuvant setting or also the adjuvant setting after their interval debulking surgery? So for neoadjuvant, we really can use any of our IV regimens that are for stages 2 through 4 disease, with the exception of that IP/IV regimen, because we do need to have the patient optimally cytoreduced before that's an option. Now, one thing to consider, we often do use bevacizumab for these patients in their upfront chemotherapy, but we do need to hold it around the time of surgery. So if we remember, we need to hold for 28 days prior to and after surgery. So oftentimes what this looks like is they have bevacizumab with their chemotherapy for cycles 1 and 2, then it's held for cycles 3 and 4 around the time of their surgery, and then continued again on cycles 5 and 6. For adjuvant chemotherapy, so after their interval debulking surgery, again, we have any of our IV regimens that are recommended for stages 2 through 4. Most of the time, if they had a good response to their treatment prior to their surgery, we're going to continue with that same treatment after their surgery. But what are some options? At this point now, you actually do have the option of doing IP and IV. it is something that is allowed at this point in time, as well as HIPEC, which is heated or hyperthermic intraperitoneal chemotherapy with cisplatin. It's actually done and instilled into the patient while they're in the OR. And so if it's something that's going to be done, they have to decide that and set it all up prior to their surgery. And this brings us to audience response question number 3. So SM completed 3 cycles of neoadjuvant chemotherapy, underwent interval debulking surgery, attaining optimal cytoreduction, and subsequently completed 3 more cycles of adjuvant chemotherapy with paclitaxel, carboplatin, and bevacizumab. Her response to therapy was a partial response, and following genetic testing, she was found to be negative for any pathogenic or likely pathogenic BRCA1 or 2 mutations. SM underwent additional tumor testing and was found to be homologous recombination deficient, or HRD. SM would like to pursue maintenance therapy. Based on the NCCN guidelines, which of the following would you recommend? A, niraparib at 300 milligrams by mouth once daily. B, rucaparib at 600 milligrams by mouth twice daily. C, olaparib at 300 milligrams by mouth twice daily. Or D, olaparib 300 milligrams by mouth twice daily, plus bevacizumab at 15 milligrams per kilogram IV every 3 weeks. All right. And so the correct answer is olaparib plus bevacizumab for this patient. And really the reason is there's a couple factors for this. One, they received bevacizumab with their upfront treatment. So it is an option, and if they responded well, we should continue bevacizumab as a maintenance. Additionally, the patient is HRD, so she actually wouldn't qualify for olaparib as a single agent upfront, because that's only for BRCA mutated patients. Rucaparib and niraparib are not incorrect. They are options for a patient with HRD after their frontline, but they cannot be combined with bevacizumab. So the way the NCCN guidelines has it as a preference is that if a patient had bevacizumab in their upfront, is to continue that as maintenance and add the PARP inhibitor of olaparib to that option. So we've spoken a little bit about BRCA mutations. They are something that we do evaluate for all of our ovarian cancer patients. We are looking at both germline and somatic testing for BRCA. What is BRCA? Well, BRCA are genes that produce proteins that aid in DNA repair. So typically, if a patient is BRCA mutated, they are actually very sensitive to our carboplatin and alkylating agents. The reason is because those lead to DNA damage. Therefore, if they're unable to repair it, they tend to be very, very sensitive to our platinum agents. And with this, we also want to know this because we want to know whether or not they qualify for any sort of maintenance therapy, and if so, which agents would they qualify for. When we look at germline and somatic testing, germline BRCA mutations are found in about 13 to 15% of ovarian cancer patients. Somatic BRCA mutations, a little bit less, at only about 5 to 7%. I've also spoken a little bit about homologous recombination deficiency. So the homologous recombination pathway is basically a pathway that is essential for DNA repair. There are several genes that are involved in this pathway, some of which are BRCA1 and BRCA2, but also RAD51, BRIP mutations, PALB2 mutations, among others. So there is additional testing to be able to determine if somebody has a deficiency in this pathway. It is a combination score, so it's a combination of a loss of heterozygosity, telomeric allelic instability, and large-scale state transitions. And if that score is high enough, then they qualify for what's considered a homologous recombination deficiency. And we would treat them and expect that they respond to things like PARP inhibitors, very similar to what we would see for our BRCA mutated patients. And so this brings us to kind of what do our options look like for primary maintenance therapies. So this is somebody who has just completed their upfront chemotherapy with something like carboplatin and paclitaxel. They've already had their surgery, and now they're continuing on to a maintenance therapy. So if they had bevacizumab as part of their upfront treatment, they can continue bevacizumab as a maintenance option. Additionally, like we spoke about earlier, if they have HRD, we do have the option of adding a PARP inhibitor to that, which our current indication is with olaparib, so olaparib plus bevacizumab. Additionally, if they didn't receive bevacizumab up front, we do have the option of still doing PARP inhibitors for these patients. Olaparib is indicated only for those who are BRCA mutated. Rucaparib and niraparib are indicated regardless of a BRCA mutation status, although they are more strongly recommended as a Category 1 recommendation if patients have a BRCA mutation. And so some of the data behind this. So bevacizumab in GOG 218 is dosing using the 15 milligrams per kilogram dose. And what we see here is a modest progression-free survival benefit. And then when they did the overall survival benefit for all comers, there actually was not an overall survival benefit. So they did a subgroup analysis and found that patients with stage 4 disease are the ones that really seem to benefit from the addition of bevacizumab. And so this is oftentimes why centers do reserve it for more of those high stage patients. Additionally, we have ICON 7, which is the 7.5 milligram per kilogram dosing for this with chemotherapy and then continued as a maintenance. With this, again, we see a modest progression-free survival benefit, and when we looked at the overall survival benefit, there was none for all comers, and they found that those with a high-risk disease, so those with stage 4 that presented with ascites initially, or those that were suboptimally debulked, those were the patients that really seemed to benefit from bevacizumab. And then we have the PAOLA-1 trial, which is olaparib plus bevacizumab. And with this, we have olaparib at 300 milligrams twice daily for up to 2 years, and then the bevacizumab for 15 milligrams per kilogram every 3 weeks for a total of 15 months. And that includes their initial that they received with the chemotherapy. And what we see here is there is an overall survival benefit, specifically with those patients that were HRD or BRCA mutated. So those are the patient population we'd be looking at for this option. And then other primary maintenance therapies, we have olaparib as a single agent. This was from SOLO-1. This was olaparib versus placebo. And this is actually, even at their 7-year follow-up, which is when they expected to be able to see an overall survival benefit, they still haven't reached the overall survival for the treatment arm. The placebo arm was at 75 months, so all very encouraging results, and it is something that is now standard of care, and every patient that's BRCA mutated should be offered a PARP inhibitor after their frontline chemotherapy. Additionally, we have niraparib, which was the PRIMA study, which was using 300 milligrams once daily, and we see a progression-free survival benefit for the all-comers as well as those specifically in HRD, and this is why it does have the indication across the board regardless of their BRCA mutation status, although again, the NCCN guidelines is going to have a Category 1 recommendation for if the patient is BRCA mutated compared to if they're wild type. It's still in there, it's still an option, but it's just not that Category 1 recommendation. So before we talk about our last agent, I do want to point out the dosing for niraparib. So there is something that is often referred to as weights and plates. For this, it's if a patient is less than 77 kilograms with a baseline platelet count of less than 150, the recommendation in the frontline maintenance setting is actually to start them at a 200 milligrams once daily dose. The reason is from the initial NOVA trial, what we found was that those patients were the ones that often needed dose reductions. So about 70% of the patients required dose reductions in the initial NOVA trial, with about 15% of them discontinuing therapy. So most often is due to thrombocytopenia. So they retrospectively looked at it to see what risk factors or what baseline characteristics patients expressed that were at highest risk for that dose reduction. So it is recommended for the upfront treatment to follow the weights and plates and do the reduced dosing for those patients. And then moving into rucaparib, which is Athena mono. This is 600 milligrams twice daily. For this, again, we see a progression-free survival in the overall population as well as a progression-free survival in those with HRD. And for this reason, similar to niraparib, it is indicated regardless of their BRCA mutation status, although, again, still going to be Category 1 for a BRCA mutated patient. All right, and so this brings us to now out of the maintenance phase to now if somebody has a recurrence with their ovarian cancer. So audience response question number 4. So we have SM presents to clinic after 10 months of olaparib plus bevacizumab maintenance therapy. Her adjuvant chemotherapy was complicated by grade 2 peripheral neuropathy. She presents today with worsening abdominal distension. A CT scan was completed, revealing new lymphadenopathy and confirmed disease recurrence. Which of the following regimens is most appropriate for SM? A, carboplatin and pegylated liposomal doxorubicin. B, gemcitabine. C, mirvetuximab, soravtansine, GYNX. Or D, pembrolizumab. All right, very good. So the big takeaway here is that it's been 10 months since her last carboplatin therapy. So because of that, she's still considered to have a platinum-sensitive disease, given that her platinum-free interval is greater than 6 months. So you are going to want to select an option that has that carboplatin backbone. Mirvetuximab currently is only approved for those that are platinum-resistant. And single-agent gemcitabine would also be in a platinum-resistant category. And then pembrolizumab we'll talk about later on, but we actually don't have a lot of indications for pembrolizumab in ovarian cancer at this point in time. Okay, so for recurrent ovarian cancer, one of the things that we want to make sure that we make note of is the fact that this is no longer considered a curable disease. So we're moving away from that dose intensity that we see and moving more toward improving symptoms, maintaining a good quality of life, while also trying to achieve a response and prolonging life for these patients. Now, one of the most important factors is to see what their platinum-free interval is. So like I said, if it's greater than 6 months, they're considered platinum sensitive, and you're going to want to treat with a platinum agent if you're able to. Platinum resistant is when that platinum-free interval is less than 6 months, and that's when you're moving towards other options. Oftentimes, these are single-agent therapies. And then you also have platinum refractory, which is they have no response to or progression while they're on a platinum-based therapy. There's really no standard of care for this. So when you see the NCCN guidelines and you see the tables, there's lots of options listed, and there's not really one that's preferred over another. So this is not something there's a standard pathway for these patients. It's really going to be based on the patient's specific factors, comorbidities that they may have, what the schedule looks like, and it's really tailored to the patient. You could consider a secondary cytoreduction for platinum-sensitive disease, but this is not something that is often pursued for patients. And then again, maintenance therapies, we have some options for platinum-sensitive disease, although this space has really changed, so we have fewer and fewer options that are available to us. So tumor testing. At this point in time, most patients should have already had their BRCA testing completed, so which included germline and somatic testing. So a lot of these patients have already had their tumors tested. But if they haven't, we would recommend that they have testing, both to know BRCA, but also to see if there's any other targetable mutations for these patients. And then an additional thing, oftentimes it's done at the time of recurrence, or if you wait until they're platinum resistant, either way, is doing the tumor immunohistochemistry, testing for the percentage of the folate receptor alpha. And again, this is for that new indication that we have recently of mirvetuximab. They do have to have a certain percentage of their tumor be folate receptor positive. And we'll speak a little bit later, we'll talk about some of the details of mirvetuximab. But at this point in time, it's oftentimes when people will jump to going ahead and doing this testing, knowing that at some point in time the patient probably will become platinum resistant once they have a recurrence. So for platinum-sensitive ovarian cancers, again, the preferred regimens are still going to be using that carboplatin or a platinum backbone. So again, you still see options like carboplatin and paclitaxel that are listed here, or you can change that second agent to something like carboplatin and gemcitabine, or even carboplatin and Doxil. You also have the option of changing the platinum agent to cisplatin, so some people will do cisplatin and gemcitabine for these patients. And then preferred targeted single agent therapy, you do have the option of doing bevacizumab for these patients if you really wanted a chemo sparing. It's not something that's going to be preferred, but it is an option for these patients. And so ICON-4 is a trial that basically reassures us that we can retreat them with carboplatin and paclitaxel. So these are patients with recurrent platinum-sensitive disease, and they received paclitaxel at 175 milligrams per meter squared and carboplatin with an AUC of 5 to 6 every 3 weeks, and this was compared to platinum-based chemotherapy. What we see is there is a median survival benefit for this with 29 versus 24 months. However, I do like to note that in this trial, there's actually a fair amount of the patients that had not received prior paclitaxel, and they do have about 75% of the patients with a platinum-free interval that's greater than 12 months. So these are patients that we would expect to still have pretty good responses to their platinum. Additionally, we have the Calypso trial, which is carboplatin and liposomal doxorubicin. So for this, it's carboplatin and liposomal doxorubicin compared to carboplatin and paclitaxel. And what we see is an improvement in progression-free survival, but no difference in overall survival. With this regimen, you do see more toxicities in the carboplatin and paclitaxel arm compared to the carboplatin and liposomal doxorubicin. And then we have intergroup, which is carboplatin and gemcitabine. For this regimen, they did carboplatin and gemcitabine, and they compared that actually to carboplatin as a single agent. For this, what we see is an improvement in progression-free survival, but again, no difference in overall survival, with more myelosuppression in the gemcitabine arm compared to the single-agent carboplatin arm. And then there's no difference in the quality of life, so this is still an option for patients. Moving into bevacizumab and the platinum-sensitive recurrence, so we have several trials. OCEANS was carboplatin and gemcitabine plus bevacizumab compared to carboplatin and gemcitabine. What we see here is a improvement in progression-free survival, but again, no improvement in overall survival, with an increase in the grade 3 toxicities such as hypertension and proteinuria, which is as expected, as those are specifically toxicities that we see with bevacizumab. And then we have carboplatin and liposomal doxorubicin plus bevacizumab versus that carboplatin, gemcitabine, and bevacizumab regimen. What we see here is an improvement in progression-free survival as well as overall survival, with actually less toxicities in that liposomal doxorubicin group compared to the gemcitabine. And then niraparib and bevacizumab, I leave this here as an option. It is a category 2B recommendation, but again, if you have a patient that wants a chemotherapy sparing regimen, this is an option. They do not compare this to any standard because they compare it to niraparib, which is just not something that we are typically doing for these patients. There was a progression-free survival benefit here, but again, it's not something that we really use unless you have a patient that really just doesn't want a traditional chemotherapy regimen. And so then MITO 16B MANGO is a trial that is showing us that you can re-challenge with a bevacizumab. So if patients receive bevacizumab in their upfront treatment, can you still give it in the recurrent setting? And what this trial showed us is they basically looked at those with recurrent platinum-sensitive disease following bevacizumab-based primary therapy, and they are randomized to a platinum-based doublet therapy plus or minus bevacizumab. We do see an improvement in progression-free survival, but again, no difference in overall survival. So it is an option for patients with platinum-sensitive disease. Just because they receive bevacizumab up front does not mean that they can't receive it in the recurrent setting. So it's still an option for these patients. So additionally, for PARP inhibitors, now I do have one correction to this slide. So actually now in the most recent NCCN guidelines, olaparib is only for BRCA mutated as well. So really in the recurrent maintenance setting, your PARP inhibitors are only indicated for those that are BRCA mutated. They are listed as a category 1 recommendation if patients did not receive a PARP inhibitor in the front line. However, hopefully at this point in time, most of our patients, when they had their front line, are receiving a PARP inhibitor. And so in that case, if they've received it in the front line, it is still an option in the recurrent setting. It's just not a category 1 recommendation. And so what led to some of these approvals? So we have study 19, which is looking at olaparib. It's looking at olaparib regardless of BRCA mutation in a platinum-sensitive recurrence. Now this uses the old formulation of olaparib, so that's why the dosing is different of the 400 milligrams twice daily. It's back when we had capsules and not tablets for olaparib. And what we did see is an overall survival improvement regardless of the BRCA status. And this was for olaparib, this was the last one to finally pull the removal. The other ones I'll show you, so the NOVA with niraparib, their overall survival, you can see that while the germline BRCA mutated patients did have a benefit, that BRCA wild type and the HRD even did not have a benefit in overall survival, which is why that indication was subsequently pulled from their initial approval. And also with ARIEL-3 and rucaparib, you'll see with that group, they still have the indicated for BRCA mutated, but you'll see even in the median overall survival for those patients, there really wasn't a benefit for a PARP inhibitor in the recurrent setting. So this is why a few years ago when we would do this presentation, these were all options regardless of your BRCA mutation status. Now you have to be BRCA mutated, and even then, if a patient's received a PARP prior, it's probably not something you're going to be revisiting, but it is still an option if you're BRCA mutated. And this brings us to audience response question number 5. So SM has now received 5 lines of chemotherapy, most recently topotecan monotherapy. She unfortunately complains of worsening abdominal pain and is confirmed to have progressive disease. She inquires about immunotherapy for the treatment of ovarian cancer. Which of the following is true regarding immunotherapy in ovarian cancer? A, nivolumab is FDA approved for microsatellite high tumors, solid tumors. B, pembrolizumab is only appropriate if MSI high, dMMR, or TMBH when there is no satisfactory alternative. C, pembrolizumab may be given as a maintenance therapy following a PR or CR to a platinum-based therapy for recurrent disease. Or D, checkpoint blockade may be given in platinum-sensitive relapse. All right, and so the correct answer here is B. Pembrolizumab is only appropriate if MSI high, dMMR, or TMBH when there's no satisfactory alternatives. For nivolumab, again, as Dr. Walko discussed earlier, that does not have the across-the-board indication like pembrolizumab does. We do not have the option of, at this point in time at least, of doing pembrolizumab as a maintenance therapy for these patients. And then checkpoint blockade is not something that we just do for platinum-sensitive disease. Now, I will say Dr. Walko was saying that we will get to a lot of the immune therapies when we're talking in the gynecologic malignancy. I'm actually going to draw your attention to the handout for that, because that's for our endometrial cancer, which is not covered in this lecture. It's just ovarian cancer, and we don't currently have a lot of options for immune therapy in ovarian cancer aside from the MSI high dMMR. So for platinum-resistant recurrent ovarian cancer, what are our options? At this point in time, this is where you start to see a lot more options. Some of our specific preferred cytotoxic regimens can be things like docetaxel, oral etoposide, gemcitabine, liposomal doxorubicin, weekly paclitaxel, topotecan, or even oral cyclophosphamide plus bevacizumab. So there's lots of options, and honestly, none of them are a preferred of those. It's not a preferred order to them. It's really based on patient preference and other toxicities that the patient may have had with previous regimens. However, we do have a preferred targeted therapy with mirvetuximab soravtansine. So this is for patients that have a folate receptor alpha expressing tumors. And what this cutoff is 75%. And if they have at least 75% expression on their tumors, then they do qualify for this agent. And so this is indicated for the treatment of, like I said, that folate receptor alpha testing positive if they're platinum resistant and they have had 1 to 3 prior lines of systemic therapy. This is an antibody drug conjugate. It targets the folate receptor alpha, and it delivers a potent tubulin targeting agent. I do want to draw your attention to the dosing on this because this is a time where we use an adjusted body weight, not a total body weight for dosing. It is 6 milligrams per kilogram every 21 days. The SORAYA trial is the trial that led to the approval of this medication. It is a phase 2 single-arm study. It showed an overall response rate of about 32%. and a duration of response of about 5.9 months, which in a platinum-resistant setting is quite promising. This is, I will tell you, in the next 5 years, this will probably change significantly because I know that there's a lot of ongoing studies to combine this with other agents and potentially moving it up earlier in the lines of therapy. So I'm sure this will be different in a few years, but as of now, we're only indicated for this in that platinum-resistant, highly expressing folate receptor patients. And so when I say there's a lot of options for platinum-resistant, there's a lot of options for platinum-resistant. We had the preferred, but for completeness, there's several agents that are listed here. And additionally, like Dr. Walko was describing, in the targeted therapy, actually now in the NCCN guidelines, we do have the option of that FAM trastuzumab deruxtecan if patients are HER2 IHC 2+ or 3+. It is indicated there as well. So I'm sure that will be changing in these in the upcoming years as well. So just kind of a summary of PARP inhibitors, because if you've taken this recertification course before, this is probably the area that has changed the most in ovarian cancer. So in terms of the frontline, we have approval of frontline maintenance for olaparib, rucaparib, and niraparib. And for that, they're all indicated if somebody does have a BRCA mutation. Now, olaparib is only indicated if they're BRCA mutated as a single agent. If they're HRD, you do have the option of doing olaparib plus bevacizumab. And then with rucaparib and niraparib, you do have the option regardless of their BRCA mutation status or if they're regardless of their HRD status as well. In the recurrent platinum-sensitive maintenance, again, they are all still indicated, but only if they are BRCA mutated. So this is not something that we are giving to patients that aren't BRCA mutated at this point in time. And then for recurrent treatment, again, none of them are really options. They're still listed in the NCCN guidelines for treatment. However, they're a Category 3 recommendation and not something you're really going to see or be recommending to your patients. I leave niraparib on there only because they do have that indication in combination with bevacizumab for platinum sensitive for that chemotherapy sparing option. And so some specifics about the different PARP inhibitors and kind of comparing them to each other. Olaparib is a 300 milligrams twice daily. Rucaparib is also a twice daily at 600 milligrams. And then niraparib is either 300 milligrams once daily or 200 milligrams once daily if you're following that weights and plates. Some kind of common toxicities that you'll see across the board for all of our PARP inhibitors. You will see myelosuppression, fatigue, nausea, and potentially changes in bowel habits. Most commonly constipation, but you can see diarrhea as well. Some specific toxicities that we'll see. So olaparib does have a rare incidence of pneumonitis and then also increase in serum creatinine. Rucaparib has hypercholesterolemia, elevated ASTs and ALTs, as well as an increase in serum creatinine. It also comes with a caveat of it does have photosensitivity. It's our only PARP inhibitor that does have a photosensitivity with it. And then niraparib has more cardiac involvement, so more hypertension and palpitations. Additionally, with niraparib, while they can all cause myelosuppression, it does have a lot more thrombocytopenia. So you will see that the recommendation for monitoring for these patients is actually to do weekly labs for these patients for the first month that they're on therapy. And that's only specific to niraparib. The others can have monthly labs. So we do have specific recommendations due to the thrombocytopenia seen with niraparib. The risk of MDS and AML is there across the board. Depending on which trial you're looking at, it's usually somewhere right around 1 to 2% of patients that can develop MDS or AML. In terms of metabolism, the key thing to remember is olaparib is cleared. It's a major substrate of CYP3A4, so we do need to think about drug interactions, and patients do need to be counseled to avoid grapefruit and grapefruit juice. Rucaparib does have CYP3A4, but it's only a minor substrate of it. It also has CYP1A2 and CYP2D6, so drug interactions are not as prevalent as what we see with olaparib. And then with niraparib, it's the P-glycoprotein, so in terms of drug interactions, it's not nearly as many that we have to worry about. So just to recap and treatment summary for our recurrent ovarian cancer, the first question you're going to ask yourself is whether or not somebody is platinum sensitive. If they are, you're going to want to continue with a platinum backbone and combining it with another agent. If they're platinum resistant, you have several options. These are usually going to be single agent therapies. And then remember, if that patient does have that folate receptor alpha positive, then they are a candidate for mirvetuximab. And so just reviewing a little bit for end-stage ovarian cancer, some of the supportive care things that we need to consider. So some of these patients do end up having bowel obstructions. Sometimes they're intermittent, sometimes complete bowel obstructions. Some things that can be helpful is counseling on a low residue diet, small, frequent meals throughout the day, avoiding agents that really slow that GI motility, and also the use of prokinetic agents are really not recommended for these patients. Additionally, we do have patients that have malignant ascites or even pleural effusions that oftentimes have to be tapped and drained throughout the end of life care. And then it's really not recommended to do any parenteral or enteral nutrition as it doesn't prolong life. Pain control, it really depends on where their disease is, but it's oftentimes something that we do have to help manage for patients. And then patient and family counseling to make sure that you're discussing the goals of care and the wishes for the patient. So I can't complete any talk on gynecologic malignancy without also talking about hypersensitivity reactions, as we have two of the major culprits that cause hypersensitivity. So this brings us to audience response question number 6. So during SM's initial adjuvant chemotherapy following IDS, she experienced a severe hypersensitivity reaction on cycle 6 of carboplatin, characterized by a cough and shortness of breath. Which of the following is the proper sequence of managing a severe platinum hypersensitivity reaction? Is it A, stop the infusion, give a corticosteroid, monitor and resume at a slower rate? B, stop the infusion, start oxygen and observe? C, IM epinephrine? Or D, stop the infusion, give oxygen, an H1 and H2 antagonist, and corticosteroid? All right, very good. The first thing that you always do in a hypersensitivity reaction is to stop the infusion. The reason we actually, for A being incorrect, is we actually would not resume at a slower rate for a hypersensitivity reaction to a platinum-based agent. There are options that we can discuss in terms of desensitizations, but it's not something we would just start at a slower rate like you might a taxane reaction. So you're going to be stopping the infusion. IM epinephrine does potentially have a role in some of those more severe reactions, but again, the very first thing you need to do is stop that infusion first. So you're going to want to stop. If there's shortness of breath, you're going to want to administer some oxygen. Your H1 and H2 antagonists and corticosteroids are going to be your supportive care for these patients that you're able to provide. Okay, so hypersensitivity reactions to taxanes. For taxanes, you're typically seeing these reactions within the first or second exposure, regardless of the dose. So whether you're using that 175 milligram per meter squared dose, or the 135 if you're reducing it for elderly patients, or if you're using that weekly 60 milligram per meter squared dose. But again, it typically is going to happen still within that first 1 to 2 cycles. Pre-medications, the regimens will vary, but it does recommend to use pre-medications. So you do have the option of doing a steroid-heavy regimen, which is the dexamethasone 20 milligrams, and you would do it 12 hours before, 6 hours before, and then 30 minutes prior to. Additionally, you can drop those 12 and 6 hour before and just do 20 milligrams in combination with an H1 and an H2 antagonist 30 minutes prior, and that's also a regimen to help prevent these reactions. By giving these pre-medications, you do reduce the risk of a mild to moderate reactions to about 40% and severe reactions to about 2%. Now, in these cases, you can stop the infusion, treat the reaction, and if the patient becomes stable, you can resume taxanes at a slower rate. And so hypersensitivity reactions to our platinum agents. So for this, our platinum agents, we'd be looking at carboplatin, cisplatin, and even oxaliplatin. These are typically more of that delayed hypersensitivity. You tend to see this after around 6 to 8 exposures. So oftentimes what we're seeing is the patients are platinum sensitive and they're coming in for their retreatment, and when they do, at that point in time, within the first 1 to 2 cycles of their retreatment is oftentimes when we are seeing people have reactions to their carboplatin agent. Additionally, there's also some data to show that the longer time that it's actually been since their last platinum, the more likely they are to react. So it's kind of counterintuitive, but it is something that we see. A lot of institutions will do, and there's very good data for doing carboplatin desensitizations in the outpatient setting and being able to do it safely. So it's not something that needs to be done inpatient. It is just a very long day because the desensitization protocols, while they vary, they last for a prolonged time, so sometimes chair time or just whether or not physically the infusion center is open that long sometimes dictates whether or not it's able to be done in the outpatient setting. These are classic allergic reactions, and there is some data for doing skin testing for these patients as well. And so I say it's a traditional allergic reaction, but what do these hypersensitivity reactions actually look like? So if somebody has a mild reaction, this may just be simple itching, rash, maybe even facial flushing, maybe some abdominal, pelvic, or back pain. A more severe reaction may include things like nausea, vomiting, shortness of breath, hypo or hypertension. And then you also have life-threatening reactions, which can be things like hives, anaphylaxis, severe hypotension, again, nausea, vomiting, and then respiratory distress. So for the acute management of just a mild hypersensitivity reaction, you're going to be stopping the infusion, and the very first thing that you should be grabbing for is your H1 and your H2 antagonists. It's because they work a little bit faster for treating their acute symptoms. If you are concerned about a delayed reaction, you can administer a corticosteroid. So still an option, but you're going to administer these medications and then observe the patient. If it's resolving quickly, nothing more to necessarily do in terms of just watching. If it's not resolving, that is when you have to reach for things like your IM epinephrine. Now, if the patient's having a more severe reaction, you're pretty much going to follow the same treatment algorithm, but you may have additional supportive care options for these patients. So doing things like administering oxygen, nebulized bronchodilators if possible, but again, you're still going to be doing that H1, H2, and corticosteroid. Now, if somebody has a life-threatening hypersensitivity reaction, you're stopping the infusion, you're placing the patient in a recumbent position, administering that IM epinephrine, you're giving oxygen, potentially boluses of saline if you need to, their H1, H2, and then depending on what your center does, a lot of times it may warrant a rapid response or a code, depending on what kind of support that you have available, because it does happen that people do have cardiopulmonary arrest from this as well in the more severe cases. And with that, that is the conclusion of the gynecologic malignancies.